Hello, my name is Paul Gross, and I'm the President and CEO of the Cerebral Palsy Research Network. And this webinar is aimed at clinician researchers, community members that are really interested in learning how the data in the CP Research Network registries can be used for doing community research or secondary analyses for new discovery. I'll be joined today by Dr. Bjornson, who's our scientific director, Dr. Gennady, who is the co-chair of our adult study group, and Dr. Rock, who's a pediatric neurosurgeon and a site investigator who's done secondary analyses in the network. So the vision of the CP Research Network is that by engaging a community of stakeholders and a vast number of health systems in a learning health network for cerebral palsy, we can collectively focus the research and care of people with CP on the health issues that are most pressing to their participation and quality of life. We will gather and share lived experiences of community members and measure aspects of the healthcare process to continuously improve their health and well-being in ways that matter to them. So some key milestones since we were founded in 2015, coming out of a National Institutes of Health workshop on CP, is we launched in our education program, we launched the CP Toolkit in 2015, and we've served more than 5,100 copies of that, both in print and online through various hospitals and through our website. We went on to release a well-being guide for parents and caregivers, and then also to translate our CP Toolkit into Spanish and Portuguese. And then in 2020, we enabled personalization in the MyCP platform, which is a web portal built on top of CPRN that allows people to access our community registry. From a research program perspective, we set out to build a clinical registry, which we launched in March of 2016, and now has more than 8,000 patients in it. And we went on to launch a community registry in March of 2019 that now has more than 2,200 members of the community in it. We are very patient-centered from the outset of the founding of this organization, and one of the first things we did was get funding from the Patient-Centered Outcomes Research Institute to put together a patient-centered research agenda, which was published in 2018 called Research CP, which really guides our work. We went on to get some significant funding milestones from the National Institutes of Health for a genetic study, and then formed a partnership with the largest private funder of CP research, Cerebral Palsy Alliance Research Foundation. We currently have 29 new studies in various stages of development or execution, and 4 quality improvement initiatives across the network. We've had 9 publications, actually 10 since this slide presentation was put together. We've done more than 39 academic presentations, and we have 5 additional manuscripts in the writing phase. Lastly, on wellness, we've partnered with the National Center for Health, Physical Activity, and Disability to offer the Mentor program, which focuses on mindfulness, exercise, and nutrition to optimize resilience for people with disabilities. The network is more than 30 centers. The green pins represent sites that are currently collecting data into the registry. The yellow pins are preparing the registry. The red pins are working through some compliance, and the blue pins are sites that have raised their hand and said they want to be a candidate to join the network in the coming months or year. So how is data populated into this registry? Well, the clinical registry is populated by clinicians through usual care. So by integrating into their notes, we make it so that there are pop-up forms or smart lists such that when they're entering data that is CP specific, it's captured in a discrete CP data element. And all of these data elements are captured the same way and have the same shape across all of the sites. And then that data is extracted and sent to our data coordinating center. There is another way in which we populate data into the registry, which is some sites use REDCap, a popular chart abstraction and research tool, to review patient charts and abstract the information into a set of forms to provide the data. And that's all captured in a centralized registry at the University of Pittsburgh, where our where our community registry is stored. Data collection in the community registry happens either through a prompt in email or a prompt from our website. And again, it directs people to a survey that's been built into REDCap. So we're able to leverage a common survey platform for most researchers, but provide research questions out to members of the community. So a learning health system is one which captures data about the care of patients to try to continuously improve. And so we have built this by providing our forms and note templates to hospitals so that when they see patients, they capture that data locally, all in the same shape around standards of care, patient characteristics, measures and scales, the different treatments they do, and various outcomes. But a learning health network goes much more broadly than just a single system. What we do at each site is we save that data into the CPRN registry, and that gives us that platform for continuous improvement. But they come together in the form of a learning health network by having multiple centers that then store their data at our data coordinating center at the University of Pittsburgh. So the fundamental unique value of the CP Research Network is how it connects the electronic medical record to the registry to avoid duplicate data entry, and that data is entered by clinicians as part of their usual care. We're also able to link those patient-reported outcome measures from people in the community registry to clinically validated data. These data together support hypothesis generation and recruitment planning for studies, and they give us a platform for sustained research and for quality improvement. It's also longitudinal, so it gives us the ability to study long-term outcomes by implementing a multi-center learning health network for cerebral palsy. And with that, I want to turn it over to our next speaker.
Hello, my name is Christy Bjornson, and I'm a professor of pediatrics and a pediatric physical therapist at Seattle Children's Research Institute in Seattle, Washington, and the University of Washington. I'm also the CPRN scientific director. Today we're going to talk about how do I develop a study using the CPRN data. I'm going to take you through a high-level look at what is in the data, what is in the data by different sites, and then also how you might be able to develop a QI or a research project from that information. Here's my financial disclosure. I receive funding for the work I do from private foundations, federal funding, as well as private funding, and I have no conflict of interest to disclose. What I hope to do today is review the CPRN core registry elements. I want to describe the clinical registry by gross motor function classifications level, or GMFCS, and age. We're going to review the frequency of GMFCS by the site, so you get a sense of the depth and the breadth of the registry, clinical registry that is, and then we're going to describe potential preliminary data within the CPRN clinical registry that could be used for QI and grant development. And lastly, how to access the CPRN data for QI and research. First of all, the core required registry elements for a participant from any site to be enrolled in CPRN are first, their gross motor function classification scale classification. Second, whether they're premature or full term or not. Third, their cerebral palsy distribution, the predominant movement disorder, and or any other movement disorder. So in this slide, you see a snapshot of the clinical registry as of September 22, where we had over 7,000 kids in the registry. As you can see, it's a U-shaped curve with almost the same number of level 1 children as level 4 children, or excuse me, level 5 children, with the least classification at level 3 and approximately 16% missing at that time. We are in the middle of a current uploading to our DCC, so this number will be larger, and we expect that the missing amount should go down as well. Now this snapshot on this slide describes the clinical registry of, again, over 7,000 children as of September 22nd. And you can see our predominant age range in this group is for children between 6 to 18 years of age. And again, we have a missing of about 16%. Now on this slide, on the vertical axis, you see some codes, and those codes represent each of the sites that are within Cerebral Palsy Research Network. This slide represents 15 sites at that time, approximately up closer to 20 at this time. The sites have updated and loaded participants ranging anywhere from 3 to over 2,000 participants at different sites. So let's take a look at the different sites. For SO68, it's an epic upload data, so it's an electronic upload. All the patients come from a set of providers of a single discipline, which is rehab medicine, with a cerebral palsy diagnosis. And they estimate they are capturing about 80% of the population. In contrast, SC65 is a manual extraction to REDCap. Patients coming to neurosurgery and spasticity clinic where they estimate they're capturing 100%, but not capturing all their cerebral palsy population, and is primarily captured through rehab med with approximately 1,500 patients per year. Now let's look at site RD70. It's an epic upload from a CP clinic that's housed in orthopedic, and they are estimating that they're capturing 100% of their kids with a cerebral palsy diagnosis. If we look at NT75, this again is a manual extraction site from an EMR to REDCap. It includes all the patients that come to a single provider appointments, such as developmental medicine, rehab medicine, ortho CP clinic, and DevMed rehab and multiple provider clinics. They present with approximately estimating that they're getting about 70% of the population. And lastly, site DI74. This is an ortho rehab type of care model that estimates that they're capturing about 70% of the population. They're an epic upload for all CP patients seen in a CP clinic. Now, what about the different sites by the core elements? And let's take a look at the core element at GMFCS level, or a vital sign for cerebral palsy, as we like to call it. This is the GMFCS level captured by the different sites that we were just talking about in the previous slide. They're either not assessed from 0 to 15% and about 1% for the full registry. The missing ranges from 0 to 100% by site, and the missing for the whole CPRN registry, again, is approximately 16%. The top enrolling 5 sites are RD70, NT75, DI74, DG67, and BE77 for over 6,200 and some total patients, or 87% of the current over 7,000 participants in the registry. So what about CPRN grant development? First of all, you could use it to develop and describe the population incidence or a representative sample for recruitment. You can look at practice variations for surgical interventions or other interventions such as injections or orthotics. You can use it for sample size description and how many sites you might need to enroll to meet your enrollment needs. And also, you can use it to describe the feasibility of data capture by site across the registry. It helps you develop the focus of your research as well. So in this slide, we see an example of the behavioral disorders that you might see in the cerebral palsy population, such as ADHD, etc. And you might want to be interested in particular comorbidities that are seen in cerebral palsy. If you look at practice variation by age, here's a slide where we know that selective dorsal rhizotomy at the time when this slide was generated was being done mostly for children between the ages of 4 and 12 years of age, for a total of 238 rhizotomies in the registry at that time. Again, I remind you that this slide is based on September of 22 data. What about the number of sites needed for enrollment? We can look at the interventions over the last 3 years by age for selective dorsal rhizotomy, multi-level surgery, or ITB. Then we calculate the number of sites needed to enroll per our power calculations. For example, the sites number calculation of 25 sites doing a multi-level surgery, the average total is 350 procedures a year per site. Thus, you need about 5 sites to do 80% of the total, and you need about 1,000 procedures in 4 years. You can use this for grant budgeting and logistics, proposing about 6 to 8 sites from CPRN for your budgeting. Here's an example from some of our data locally in Seattle. As you can see, we have a distribution in this slide of about 1,400 patients, and we have a strong ability to enroll children from about age 4 up to about age 18. Again, the same thing with our GMFCS distribution. Since we're a tertiary care center in the Pacific Northwest, Seattle has a higher number of kids at GMFCS level 5, but we have the ability to enroll kids at 1, 2, lesser ability at level 3, and clearly at level 4. Also, the feasibility of data capture by our Seattle Children's site. As you can see, we have proposed etiology from HIE, IVH to PVL, white matter injury, congenital affection, and etc., depending upon what your research question or your QI question is. Want to work with the CPRN registry data? What you need to do, first of all, are you a member of CPRN? If not, please join or help your institution join if possible. If that's not possible, then I want you to seek out investigators or CPRN sites and have a collaboration so that you and a CPRN site investigator can join together to develop your research or your QI idea. Once you have an idea, be sure to browse through the studies on our website to see what we're already doing, and maybe you can build on that work or collaborate with the people who are working on it as well. Then once you have an idea, please reach out to myself as a scientific director. I will help you develop your idea. If you need training or support, biostatistical support, we'll either find it for you within CPRN or also locally with the other CPRN site investigator that you're working with. You will form your study team, you'll develop your concept following our templates that are found on our website, and then you'll follow up after that with the research concepts standard operating procedure, or SOP. Thanks for your time, and I look forward to any questions. Have a great day.
Hi, I'm Brandon Rock. I'm a neurosurgeon at Children's of Alabama, the University of Alabama at Birmingham, and I'm here to tell you a little bit about using the CPRN registry for research, specifically by giving you an example of a study that we're working on variation in patients getting selective dorsal rhizotomy. I have nothing relevant to disclose. So as you're probably aware, rhizotomy is an operation that's done to reduce spasticity in children with cerebral palsy. There's also a tremendous amount of variation in the way selective dorsal rhizotomy surgery is done. So setting aside the potential variation in how patients are referred for surgery or selected for surgery, there are a lot of variations in the way that surgery is performed in the actual surgical technique. So, for example, as seen here, this is from a paper several years ago. This just depicts some of the different options for the bony exposure that's done in order to get to the nerves where a rhizotomy is performed. And there's lots of different ways to do this. In addition, there's a lot of variation in where the nerves are accessed, how dorsal nerves are identified versus ventral nerves. Again, this is a dorsal rhizotomy, so picking dorsal from ventral is an important step. Lots of different ways that this is done. We did well, here's an example. One place you can do this dorsal versus ventral selection. Here's another. In addition to that, there have been some studies on the various techniques for how a nerve is selected, right? What type of electrical stimulus is used to pick out which nerves are more active, which nerves are less active, and thus picking which nerves should be sectioned in rhizotomy. And there's a tremendous amount of variability in that technique as well. We performed a special session at the 2020 AANS and CNS Joint Section on Pediatric Neurosurgery meeting, where several experts in rhizotomy, surgeons who perform rhizotomy, gave a brief presentation about their surgical technique and how they perform the operation. And it's really quite amazing to see how many different ways there are of doing this operation. So we set up a study using the data in the Cerebral Palsy Research Network registry, the CPRN registry, to really kind of quantify this variation, categorize this variation in rhizotomy technique. So step one is figure out what data are available. And as you can see here, we can use the CPRN registry elements report in order to get an idea of just how many patients there are in the registry that have these data. There's a little bit more granular data available for these reports now as well, and this is evolving as the Data Coordinating Center makes progress. But you can see here we have several patients in the registry that have had rhizotomy, so a good population that we might be able to study. So the next step in the CPRN process is for the potential investigator, in this case me, to create a concept cover page. And that includes these elements here, as you can see, a plan for funding, a little blurb about the importance of the topic, how CPRN is going to be able to address this, et cetera. Some discussion of the methodology, sample size requirements, and so forth. So I put together this cover page, and then the next step is to give a topic presentation, a concept presentation to the CPRN membership. So here you see a nice screenshot of me. Look at that, sitting in this very chair, in this very office, talking about this topic to the CPRN membership. After this, there is a vote by the investigators on whether we should proceed. And once that is done and approved, the next step is to meet with the CPRN data coordinating team. Here you see Dr. Stephen Wisniewski, who is the leader of the data coordinating center at the University of Pittsburgh. So some back and forth conversations by email and phone and Zoom to really nail down what data we need, and then the DCC can go ahead and produce the reports for us. And I'll give you a little teaser here. This is a summary of the total number of patients in the registry who have had rhizotomy. You can see there are 182 children. You see the breakdown in sex, race, GMFCS level, movement disorders. And so we're working on analyzing these data right now, and with a plan to put forth a paper in the near future on the variation in rhizotomy technique captured by the CPRN registry. So in summary, what this allows us to do is leverage the large size of the CPRN. So a lot of patients in this registry. This specific study will allow us to frame future research questions, and it will help us really nail down what additional variables are going to be needed for future studies to make this research more impactful. For now, it's only a study of variation, but hopefully in the future it will be a study of outcomes as well. It's an overview of how we use CPRN, how we can perform these data analysis, the investigators involved. And then, of course, this also represents an academic opportunity for young investigators. This is a great data set that is here. It's in existence. If you have an idea, a clinical question that you want to ask, this may be a good way to answer it and potentially provide some career advancement. So my pleasure to be able to talk with you about this today, and I appreciate the opportunity. Thank you.
Hi, my name is Mary Giannotti, and I am a physical therapy professor at the University of Hartford. I'm one of the founding original members of the Cerebral Palsy Research Network, and I'm here to talk to you today about the community registry and my CP. In terms of financial disclosures, I'm a consultant for the Shriners Hospital for Children. I have grant and research support from the American Physical Therapy Association Academy of Pediatric PT and from Rifton Company. I'm an employee of the University of Hartford, and I won't discuss any off-label investigational uses of drugs today. An outline of the presentation is: first, I'm going to review the purpose of the community registry. Then I will discuss the process of enrollment. I'll present some of the results from the current survey, and I'll discuss opportunities for interested researchers. First of all, I'm going to tell you about my CP. My CP is a free, private, personal portal that allows people to get into the CP Research Network. And when you register, you can get personalized educational recommendations if you're a person or a caregiver of someone with CP. There's exclusive content in terms of the latest research that's being performed by the CPRN investigators. You can participate in research projects if you meet inclusion criteria. There's a forum for discussions, and we also offer some free fitness programs. Here's a screenshot of what it looks like when you enter the forum, and the forum is personalized to your own interests. This is a forum of my interests, so we're talking about things that concern adults with CP, and you can see that there's a lot of views and activities, and you can participate in ongoing discussions to sort of negotiate and see what other people in the community are experiencing, get ideas, brainstorm, network, and referrals. In terms of the community registry, there's, I want to talk to you about the structure. It is both cross-sectional and longitudinal. There's a base set of tests and measures that are offered to participants that meet specific criteria, and those questions are offered one time. In terms of the longitudinal portion, we repeat the base set on an annual basis for those that are willing and able to participate, so that we can track changes over time. To give you an example, We have both a pediatric registry for those people that are under the age of 18 and an adult registry for those that are over the age of 18 and can provide legal consent. Both registries have a base set of annually deployed survey, and we'll get into more details specifically about which surveys are deployed. And we also have short-term surveys. An example of a short-term survey that was deployed for children was by Dr. Allison, which she talked about speech and language predictors for children with cerebral palsy in terms of their ability to participate in society. Similarly, on the adult side, Dr. Liz Boyer performed a short-term survey asking adults with CP who ambulate about the consequences of falls. And both of these, the results of both of these surveys have been presented in webinars that you can also access. Generally, both surveys, the adult and the pediatric community registry, have this sort of format. We have basic information about age, CP typology and distribution, functional levels, gender, race, and ethnicity. Then we ask more specific information about your medical history, devices, illnesses, fractures, prior medical or interventional procedures, and your developmental history. Excuse me. And then we do a little bit of a deeper dive into function. We have the adult surveys on pain and function, and we have pediatric surveys on pain and function. Right now, the overarching purpose of the adult surveys is to really look at patient-reported information and ask them questions about their experiences since childhood. And we're going to ask about changes in their gross motor abilities, their ability to speak or use their hands. We're going to ask about perceived reasons for the changes and questions about their overall well-being. Then we have a deep dive where for those with pain, we ask them about chronic pain, the treatments that they've sought, their use of opioids, and their overall well-being. So to give you more of a schematic, people enter into MyCP and they enroll here. We gather their information in terms of their clinical information. These are for adults with CP. For the functional change survey bundle, we have GMFCS, MAX, and then we ask about communication and why they thought they declined. We use the NIH Promise 29 CAT form, and we use the NeuroQOL stigma form, perceived stigma. And these are measures that were developed by the National Institutes of Health. For those that have chronic pain, so we ask the question, if you have chronic pain, yes or no. If you have chronic pain, then they're directed to the chronic pain survey bundle. We use the brief pain inventory, which is the standard measured by the International Association for the Study of Pain. We use the PROMIS measures of anxiety, depression, satisfaction with social roles, and pain interference. Then we also classify people using the NeuroQOL upper extremity and lower extremity function questionnaires. And all of the PROMIS measures are catted. So there's increased brevity because depending on people, how they answer, we can accelerate or expand out the questions. So it can be anywhere from 3 to 5 questions for the PROMIS computer adaptive testing modules. Then we use the current opioid misuse measure for the patients that use opioids for pain management. Currently in the adult surveys, we have 557 with a mean age of 42 that are primarily female, primarily ambulatory, although we do have 80 people who are using wheelchairs and not walking in GMFCS level 4. We only have 20 who are in GMFCS level 5 that have difficulty with a lot of different mobility skills. In terms of pain, we see a similar distribution of GMFCS level and age, but smaller numbers. We have 333. Total, we have 8 in GMFCS 5, 39 in GMFCS 4. In terms of the medical history, we have 402, and we have a really robust number across the GMFCS level equivalent to the functional survey. We also have more than 175 longitudinal responses, and those are folks that have answered the survey on an annual basis for up to 3 years. Just to give you a sneak peek into our preliminary analysis, you can see that there's GMFCS was associated with functional decline, and we can see that the folks that are really at risk for decline, the 2s, the 3s, and the 4s, the people that ambulate with difficulty and then with assisted devices or very short distances, report the most decline, which is not surprising. In terms of the pain, we found, which is not surprising, the low back, hips, and knees are most painful, and they're the most painful and most commonly reported. And they mostly also have really highly reported pain, that the pain is like 8 to 10. In terms of our pediatric surveys, the overarching purpose is to collect patient-reported information about the children with CP from their caregivers, again, about their medical status, their interventions, and their child development. And then we want to know about their functional abilities and their caregiver child priorities and concerns. And we use the CP child and the CP goal for that. So again, the overall structure for the pediatric survey is the demographic suite of questions that we ask, same as the adults. And then again, the same questions as the adults for the medical conditions. And then the CP child and the CP goal. And both of these would be reported by the parent. These are parent reported, not the child reported. In terms of our pediatric surveys, we have a much smaller N. We have 48 for the goal, we have 53 for the CP child, and we have 121 for medical history. And then you can see that we have about a mean age of 11, and that our GMFCS is, not completely distributed across all the levels. So we need some work in terms of developing the robustness of the enrollees in this registry. In terms of opportunities for other investigators, either inside or outside the network, there's the ability to initiate secondary analysis, either cross-sectional or longitudinal, by looking at the code book and coming up with questions and then going through the flowchart process for proposing a research project to the Cerebral Palsy Research Network. There's also the possibility for an investigator follow-back survey, and Dr. Julie Stusbeck at Regis University is doing a study right now where we're following back people with low back pain from the chronic pain study and asking more in-depth qualitative interview questions about their experience with treatment and how we may or may not be able to find some targeted interventions. You can also develop your own initiated short-term survey like Dr. Allison or Dr. Boyer to answer some questions that are really important to you. I thank you for your time and your attention, and I hope this was helpful. Here's my friend Lucas, who's part of our high-intensity exercise program at the University of Hartford, a young adult with CP who's really excited about embracing all the new evidence to help him live a long and happy life.